This meeting will be recorded and uploaded to the OHA website. Welcome, everyone, to our second Provider Reimbursement Technical Advisory Group meeting. We're going to start by overviewing the agenda. As I indicated, we've got a packed agenda today. We're going to be talking about individual provider reimbursement models and methodologies. Dr. Chadwick will walk us through his own personal analysis of the pros and cons of the various methods that are at our disposal. We'll have some time for us to talk through, for you all to talk through your thinking and thoughts, reflect back on Dr. Chadwick's analysis, and then we set aside some time to address a couple administrative questions that were lingering at the end of Wednesday's task force meeting. And then finally, we have a standing wrap-up agenda that we instituted at our last meeting. I heard from you all that it would be great to set aside time to talk through specific questions for the Consumer Advisory Committee, to talk through what Dr. Chadwick will be reporting back to the task force, and discussing our upcoming meeting. And then lastly, this is a public meeting, and this will be the first TAG meeting that we do offer time at the end for oral public testimony. If there are folks that have already logged on and joined this Zoom, if you could please chat in the chat box that you would like to be providing oral testimony, Sarah Nipper will be monitoring that, and that way we can get you all set up. So we have 10 minutes at the end. I'm going to take a beat and ask you all, Dr. Chadwick, is there anything else that you want to add in this agenda overview? Any other introduction that you'd like to offer?
No, I think we're good to go unless other people have thoughts about it.
Okay, so let's talk about provider types. I think it would be helpful, we thought it would be helpful to start by defining our terms. Senate Bill 770 defines provider as an individual provider, institutional provider, or a group practice. We have discussed that this definition might not be the most ideal definition, and that there might be some categories of providers that don't necessarily neatly fall into those three categories. I'll address that in a second. But for now, let's talk through these three categories that the bill does define. As a reminder, today we are focusing on individual providers. We're actually going to define and talk more about institutional providers at our next meeting. Today is going to be focused on individual providers and on group practice. We'll speak to that in a second. Group practice does fall more squarely within the scope of a conversation of individual providers than institutional providers. So individual providers, what are they? These are healthcare practitioners who are licensed, certified, or registered in this state or in another state or another country. This includes physicians, it includes primary care physicians, hospital-based physicians, procedurists, non-procedurists. It additionally includes non-physician providers, so chiropractors, acupuncturists, advanced practice clinicians like nurse practitioners and physician's assistants, certified nurse midwives. It additionally includes nurse anesthetists, clinical social workers, counselors. This list is by no means exhaustive. It's an attempt to outline the real range and breadth of services that individual providers provide. It barely scratches the surface of the range and scope of services that individual providers provide. Dr. Chadwick, is there anything else that you wanted to add? I know that this was a list that you initially did pull together, and I just want to check in with you. Is there anything else you want to offer in this when speaking to this list?
No, other than just to take note of the discussion that happened on Wednesday regarding these categories a little bit, and the possibility that there are other people that provide services under the auspices of the state or of a government entity or of another entity that don't fit cleanly into this category, and that we need to take note of that and make sure that we have taken that into consideration.
Great.
I was wondering if Cheryl or Dwight had any comments about that or anything.
I appreciate that. John Santa asked a question about the various unlicensed behavioral health workforce types. And I was thinking I would put together a list of all of the different behavioral health provider types and kind of a description of the services they provide and whether they are reimbursed by particular payers. I think that that might be enlightening, but I don't have that for you today. I'll work on it.
That'd be great, Cheryl.
Okay.
Hi. No,
Go
go ahead.
ahead. I was just going to say, Cheryl, I'd be glad to help with that in any way that I can. I think you've summed up the issue nicely, and if there's anything I can do to support your work, just let me know.
Thank you. I'd be happy for your help.
Okay.
Deborah, anything else to add?
Sure. I think that, and I could believe Xenia brought this up as well. Community health workers. We're trying to figure out how to, get them addressed under this as well, and perhaps some of the CCO and other local efforts. So to make sure that that's there. And I know that whenever we're talking about our advanced practice nurses specifically, rather than try to list out all of the professions that go there, we usually just cite the code that would then list everything that we may not get to fully in this list. So just want to say that that might be another way to reference by the statute where they are licensed.
Perfect. That's helpful. And as a spoiler, we've got, I mean, frankly, I think we just discussed this, but I did want to reiterate that there is this bucket of providers that don't fall neatly into individual provider, group practice, institutional provider. And as you said, community and traditional health workers are there. Since we're here, I'll stay on this slide and highlight, I know I've also heard substance abuse and IDD. Those are also providers that might not neatly fall into these buckets. So I wanted to make sure that we have, as Dr. Chadwick said, that we kind of have this in our minds as we're thinking about these various reimbursement models. Just to go back, so as I said, the bill does define providers as individual, group practice, institutional. Group practice is really, adding the term there of group practice, I think is really an intention to differentiate between group practice and institutional providers. Group practices are single legal entities consisting of individual providers. I think the main distinction here is really the income and where the income goes. In group practices, the income is shared among the individual providers, whereas in the institutions, the income and the overhead expenses of those of that work goes to the institution itself. I think we all know what group practices kind of look like in the real world. These are really just affiliations of individual providers that share resources and share overhead. But again, the overhead expenses of and the income from the group practice is shared among those individual providers, which is why it falls more squarely in the conversation of individual provider reimbursement.
Laurel?
Yeah.
I think another area, the reason they're sort of drawing it out separately is because the statute permits capitation for group practice. And I'll go into sort of the details of capitation, but I think because the practice of capitation for group practice works, and as we'll discuss later, it doesn't really work on individual providers, I think they needed to carve it out separately for that reason as well.
Fantastic, yes. Thank you for calling attention to that. So let's get into the main course here, provider reimbursement models. Generally speaking, there are two broad categories of provider reimbursement models, fee-for-service and alternative payment methodologies. Fee-for-service, let me first say, I think that this is information that we all know, that we're all familiar with. We heard last time that it would be helpful to provide kind of this overview and shared understanding of methodologies and how they are being applied in Oregon. And so that's what we're trying to do here. I don't want to at all make it suggest that this isn't work that you all aren't intimately familiar with. Among all of us, among all of you, we have decades of experience in this work, so I want to make sure to acknowledge that before diving in here. Fee-for-service, as we all know, is the traditional method of reimbursement. This is assigning a specific dollar amount to a specific service. These rates are determined between payers and providers, and what that results in is pretty extensive variance in reimbursement rates across services, across geographies, and across providers. The biggest critique of fee-for-service reimbursement is that it may incentivize quantity over quality. Because you're billing for each individual service, there might be an incentive for a provider to be providing services that may not be recommended in best practice in order to secure that reimbursement. In order to address that critique, which we have seen in is not just a critique in theory, but we have seen that it can lead to ballooning costs. In order to address the rising costs, especially over the past 2 decades, there's been a shifting focus from fee-for-service reimbursement towards alternative payment methodologies. Alternative payment methodologies are all non-fee-for-service payments. The goal in alternative payment methodologies is to incentivize quality over quantity, ultimately improving health outcomes. So we have fee-for-service, specific dollar amount paid for every medical procedure or service. I'm going to now go down the broad categories of provider reimbursement models. I'm using the categories and definitions that were provided in the Congressional Budget Office report that I sent your way earlier this week. We have fee-for-service reimbursement models. Bundled payments is an alternative way to be reimbursing. So instead of billing for each individual service, there is a general reimbursement amount for the procedure or for the bundle of services. Labor and delivery is a perfect example of this, as opposed to an OB-GYN billing for each individual service that is provided in a labor and delivery. They can bill simply for the bundled code for labor and delivery, and they can add additional services on top of that, but that bundle does encapsulate the services provided, generally speaking, in labor and delivery. What that means is that an OB-GYN might not provide all of the services that that are listed under labor and delivery, or there could be some services that aren't captured in that labor delivery code, but they still get reimbursed for that one bundled rate. Is there anything else that any of you want to provide, or anything that you want to add with regards to bundled payment? Dr. Chadwick will be diving in more into the pros and cons, but I just realized instead of me just spitting this all at you, please feel free to weigh in. Okay. Global budgets. This is a payment methodology that it applies more so for institutional providers, and so we'll talk about this more next time around. But this is usually a fixed payment amount for a specific time period, which is different than capitated payments, which are specific payments that are paid monthly or annually per patient. So increment for capitated payments is the patient, whereas the global budgets is the time period. Additionally, you could have a system where providers are simply paid a salary, and that salary is intended to not address the services, but simply reimburse the provider for those services. And Dr. Chadwick will go into his own analysis of why that might not be of when that might be helpful, or when that might not be the most helpful, depending on the system that we're considering. And then lastly, we have value-based payment. And so this is a system whereby the carrier identifies certain outcomes that are desired, certain care that is desired, and incentivizes focusing on those services or on those outcomes. And so an example of this would be, if there's a specific, if we want to see X number of patients receiving a vaccine of some sort, that the providers can get an additional reimbursement if they meet certain markers for that vaccine. We're going to talk more about VBP in a second, because this has been a real focus in Oregon over the past decade, really, and moving forward. But this is the general overview that CBO provides. I'm going to pause here. Anything to add? Okay. So the Oregon reimbursement landscape. So generally, payers in Oregon can be broken down into Medicaid providers. These are coordinated care organizations. We have PEB and OEB, the payers for public employees and educators. We have the employer market, group market. We have folks buying their individual care on the individual market. We have Medicare, and then we have that 6% of folks who remain uninsured. This slide highlights that in 2018, OHA purchased care for 1.3 million Oregonians. It was the largest purchaser of healthcare among these payers, which is important to consider the ways that OHA can try to leverage its payment to be, try to leverage payment methodologies as the largest healthcare purchaser. Leverage those methodologies to be, to be decreasing costs and ultimately improving quality. Deborah, did you have something to say?
Yeah, I had a question. So I see that only 15% is Medicare. Does that mean we are a relatively young state, or does that mean that a lot of our more experienced workers are still in fact working and getting their insurance through their employers?
That's a great question that I don't immediately know the answer to. Please, I'd love to hear what other folks have to say on that. Dr. Chadwick, I think you're on mute. No, we still can't hear you. There you go. There you go.
Okay, sorry about that. There's new technology here. I think that this slide, it doesn't exactly answer your question, Deborah, but this slide is numbers of people as opposed to dollars. So if you were to do this slide by dollars in the healthcare system, it would be radically different. The Medicare dollar is typically between 50 and 60% of the healthcare spend. That's because us old people get sick a lot more than everybody else, and so we're demanding a lot more resources. I don't know how this slide, in terms of numbers of people, compares. I would say that there are people that get their Medicare through an employer group market, and so it probably understates the pure Medicare. It may also understate the Medicare Advantage. You may not be in that as well, and so it could be elsewhere. And then the last thing is anybody that's Medi, that is in a Medicaid and Medicare, disabled older people or something like that, they could actually be captured in the health plan, the Oregon Health Plan category. So it's a little hard to know because some of these crossover boundaries.
Yeah, thanks, Chad. I think in my mind, I'm just trying to frame sort of the trend. You know, if in fact it's mostly young folks, then we can sort of hopefully anticipate, you know, again, that employer group staying the same over time. Whereas if in fact, you know, that space does occupy a lot of older, more experienced workers who may be shifting into Medicare, that would be perhaps pulled out of the universal bucket. You know, that gives me other considerations. So thank you.
Laurel, this is Sarah. Can I make a comment on this?
Please, thank you.
Yeah, so yesterday in the EBA tag, we looked at this data a little bit more over time. And just kind of, Deborah, to your comment, so this employer group market has remained extremely stable as far as around one half of Oregonians have been employer group market, including PEB and OEB, since 2008, 2009. Our share of Medicare has expanded a little bit, I think from maybe 11% to 15 or 16%. But that group market has been extremely stable for several years. So
That's helpful, Sarah. Thank you. So I wanted to highlight, you know, as the largest purchaser of care, what has OHA been doing to try to be leveraging its role as the largest purchaser? Jeremy Vandehay, Director of Health Policy and Analytics, presented to the task force back in August, I believe, and this was the slide that he presented at that time. I just wanted to remind everyone that that the state has been on a journey over the past several decades taking on healthcare transformation. And especially in the past decade with the launch of coordinated care organizations as the entities administering Medicaid, the state has had an opportunity to be using the CCO model to be implementing new and creative payment methodologies, really. And there has been a real focus on value-based payment, both in CCO 1.0, but also in CCO 2.0. 2020 was exciting because it was the launch of CCO 2.0, the second iteration of our CCO model. And there was an even bigger focus on value-based payment. So value-based payment, as I said, is a general term that is used to highlight reimbursing providers, not for each individual service, but instead highlighting that there is instead reimbursing for quality with specific targets. And the state has acknowledged that not all VBP payments are created equal. So you have pay for performance, which you can see here is considered a category 2, which is so what I indicated earlier, the example that I gave on vaccines. So this is either, you know, bonuses for reaching various targets or additional dollars added on every time that a targeted service is provided. If you move down the line to category 3 and category 4, these are more complex methodologies of value-based payments that involve sharing risk. we don't have time to really dig into all of this, but I wanted to highlight that especially with the launch of CCO 2.0, there was the creation of the VBP roadmap. And this roadmap essentially directs CCOs to be moving in the direction of increasing the percentage of their payments that are value-based. And not just general value-based payments, but again, putting emphasis on more complex value-based payment methodologies that do involve that incorporation of risk over the next 4 years.
Laurel, can I
Yeah.
just go back to that just one sec?
Yeah.
You know, I think that when we're thinking about the effect of the CCOs and value-based payment, it has two effects. While it is only really have a direct bearing on Medicaid, it does serve to influence all of the healthcare system to move in that direction. So it sort of has created a learning opportunity for all elements of the healthcare system that provide services to Medicaid on how this works and how they can achieve success under that environment. So we shouldn't worry too much the fact that right now it's only about 25% of the total number of individuals, because it is a great experiment with success and everybody's influenced by it. Thanks.
I'm so glad that you brought that up. And I will say that I was a little sneaky this morning and added in 1 or 2 slides that you haven't seen yet. And one of them is speaking specifically to the ways that the work that CCO 2.0 has been doing is impacting the broader scope of payers. This is, you all know, we have discussed, generally speaking, the Sustainable Healthcare Cost Growth Target Implementation Committee, which is a committee implemented as a result of Senate Bill 889 that essentially is charged with getting a handle on cost. I'll go back here. We have seen that healthcare costs are rising, and they're rising at a pretty alarming rate. And so the Sustainable Cost Growth Committee, again, was charged with thinking through ways to get a handle on cost. And one of those ways was trying to align efforts across public and private payers. So as you said, Dr. Chadwick, that VBP roadmap that I just presented was a VBP roadmap specifically for CCO 2.0 for CCOs for Medicaid. But those principles really are principles that we want to see applied across payers. And so there is an effort to create these principles that align essentially the value that align the value of value-based payment, that outline that you know, there is a real need to be reimbursing for value and not just for quality and not just quantity. And the idea is that these principles will ultimately be adopted and that there will be a voluntary compact that can be signed by both public and private payers. So thank you for bringing that up.
Just one more comment, because I think this will sort of reside underneath people's sort of subconscious, which is, you know, the fine line between measuring outcomes and these kinds of value-based payment models that achieve the outcomes, and something that could cross over into what could be construed as rationing. And it is a very delicate balance, and a lot of consumer groups are very concerned about the sort of insidious nature of value-based payment as it relates to subsequent, you know, actual rationing.
Deborah?
Yeah, the only thing I would add to that is, again, when we talk about the models that are currently in existence, just even thinking about value-based as a frame, right? Value to who? right? So I think that we, again, if in fact we're in service of helping communities and individuals' lives to be what their ultimate goals are in terms of acquisition of health, that we also have to just, not simply look at, which data set also ladders up to the federal reporting, and then we're going to identify those things as the things that we're going to focus on in terms of value.
So thank you so much for both of those comments. I think, everyone's spot on that we need to be, really thinking about, Chad, from your comment, the way that various stakeholders are grappling with this shift in focus. And Deborah, I think, your comment is really another comment to stakeholder engagement and who is determining what is valued. So I'll put a pin in the fact that we're going to talk a little bit about stakeholder engagement down the line today. Before moving on, I do want to just note, I jumped past this slide because I was so excited that we were sort of on the same wavelength. I do want to highlight that Oregon is one of the few states that actually collects data on payment types. And so, as I noted, there was an emphasis on VBP even prior to the CCO 2.0 VBP roadmap. And so this is data from 2018, again, prior to implementation of CCO 2.0. But even in the first iteration of CCOs, of the CCO system, we saw that the emphasis on VBP was not just an emphasis in theory, but that it really did play out in practice. CCOs were the most likely to they had the highest percentage of their payments linked to quality. And you can see here sort of the ways that other payers shook out in that distinction between payments that were fee for service with no link to quality versus payments that did have some link to quality.
And then Laurel, the one that's not on that slide is Medicare. So Medicare Advantage is on there, but not Medicare, not straight Medicare, because that is completely unmanaged at this point in time. Just kind of an observation about that.
Thank you. Okay. Dr. Chadwick, I'm going to pass it over to you.
Okay, let me just begin by reiterating what's said here at the bottom of the slide, which is, this is really my opinion and my sort of quick look at my thoughts about these various payment methodologies as a result of my career experience in the industry. I may have missed things. I may have gotten some things wrong. I may not have a perspective that's very important to have here. So I want to put those caveats in there before we proceed. The other thing is, I think we'll have enough time to have a few comments as we go along. So if there are questions or additions or thoughts about these things, somebody raise a hand and try to shut me up, and I'll try to get those. As we discussed, we're really focusing on individuals and also group practice. Those are a little bit different, but we'll sort of throw them into the same bin. We're going to take a look again at fee for service. We're going to look at capitation and the notion of risk associated with capitation. Then case rates, bundled payments, and salary. I think the thing I want to point out is when you look at value-based reimbursement, value-based reimbursement can thread through all of these different methodologies. It is not really key to one. It is more that it is another indicator that is placed in there to incentivize people to behave in a certain manner. So I don't address that directly, but I just want you to sort of think about that value-based reimbursement is a thread that can really be in most of these various subcategories as well. In terms of fee-for-service, just in terms of what fee-for-service is, fee-for-service is really a fee schedule that it serves as the basis for sending a fee for reimbursement out. It's no different than if you took a car in to have it repaired. There would be a variety of things off the bill. Each one would have $1 associated with it. So in fee-for-service, it theoretically, it does take acuity into account because people can send bills out for various services, and the more acuity, the more services are offered. So I think that the feeling is, if anything, it maybe takes acuity into account too much, but it certainly takes it into account. It can offer comparability between clinicians, but it isn't necessarily so. And the reason is because when Laurel was talking earlier, she was referring to the idea that fee schedules are negotiated. And that may or may not be true with all providers, but it is true commonly. And that means that the fee schedules may be somewhat different. Nowadays, most healthcare plans are compensating not on the fee schedule of the provider, but based on their own fee schedule, which is becoming more and more common. So it is offering a greater comparability, and as a result, there is more comparable data available now for fee-for-service. I say here it's used by Medicare for 35 years. That really is true. Medicare does compensate individual providers based on a fee schedule. It's based on their fee schedule, so it's very comparable. It's not a negotiated fee schedule, but it is a fee schedule that takes acuity and takes intensity and so forth into account. I mention that because one of the underlying threads of our discussion throughout this whole endeavor of the task force is going to have to do with a Medicare waiver. To the extent that we're comfortable in any part with the way Medicare compensates providers, it may mitigate the need for a Medicare waiver. And that is a big variable. I think the thing that I received yesterday from Sam Metz said only Maryland has received a full Medicare waiver. So it's a pretty heavy lift. And so I just want to make that point. And of course, it works in urban and rural areas, and the providers generally think it's fair. Typically, the payers are not so enthused about it because it's created a huge amount of inflation. I'll give you one example. When Medicare first came in '65, they had basically, you send us the bill, we pay the bill. And that created a huge inflation over the subsequent 20 years. People were left in the hospital. We had people, length of stay, you may recall, was 10 days for labor and delivery. Everybody was hanging around, and it created a huge amount of cost in the healthcare system. So while it's perceived as fair by the providers, oftentimes the payers don't think it's really quite as good. From the standpoint of the cons, things that may be opposed to it. Oh, Cheryl, I'll stop. You had a comment.
I know I'll say this a few times during this task force and our tags, but Medicare is one of the worst payers for behavioral health. So this fee-for-service model of Medicare wouldn't cut it. For one thing, it doesn't pay most of the providers in the behavioral health system, and it doesn't pay for a huge amount of the service array of the behavioral health system. So we'd have a problem with that on the behavioral health side.
Thank you. Yes, of course. And that is true for everybody, actually, because even clinical healthcare hospitals and medical centers and so forth find Medicare to be one of the lesser favorable payers, and they make up for it from private payments. So the level of payment, even notwithstanding your comment on behavioral health, is not ideal, but it is very familiar. So as a mechanical tool, for those that it does do reasonably well, it's something to consider.
Dwight?
We're not, yes.
Yeah, I just wanted to echo. I think that I hear what you're saying about the Medicare system not working in the medical field as well either. But from that standpoint, it's more of a reimbursement issue than a coverage. And I think for the behavioral health system, Medicare is really based on a medical model. And behavioral health does not work under that medical model of care. And so, you know, as Cheryl was elaborating on, it really does not reimburse a lot of behavioral health services. Addiction treatment, it's an abysmal provider. It's next to none for addiction treatment. So there's a lot of, you know, if we were to look at the Medicare model and not going after a Medicare waiver, I think the system isn't going to work if it's predicated under Medicare.
Right. I understand your point here, and I'm just making a comment that as a mechanical tool, it has worked for the medical model to some extent. Even if the rates are not adequate, the mechanical way they go about it has worked. But of course, the benefits have been so paired that the mental and behavioral health have been trimmed right out of it. And so I get your point fully, Dwight and Cheryl. So the other thing about fee-for-service is it's an enormous administrative cost. It's a big burden to billers. It's a big burden to payers. It's a burden to everybody to go through. If anybody has gotten a bill from a hospital, they'll know exactly what I'm talking about. It's arcane. It's at the very detail level, and it creates an unusual and inordinate burden. Next slide, please. Another approach that has been used is capitation. The notion of capitation is that you're taking responsibility for a particular set of services for a particular individual on a monthly or annual basis. So you're getting actually a prepayment, and you're then taking full responsibility to take care of that patient for that period of time. That offers some predictability. So to that extent, the organizations get their money up front. It does not typically lend itself to individual providers. It is comparable to some extent. It has sort of a manageable cost structure by payers. The payers typically like it because it moves the risk down to the provider and takes it away from either the state for private insurance plans. It works in rural areas and urban areas, typically about the same. And it is very low admin to manage. You just identify all the people that are in your plan. You make a payment at the prearranged amount, and the payers, insurance, or government entities are out of the picture after that point. The problem with it is, of course, it creates an incentive theoretically to reduce care. You've gotten your money up front. And so anything you can do to hasten or delay care or refer off to somebody that is not in the capitated system, it's in your financial interest. So there are a lot of uncomfortable areas with capitated as a payment methodology, and it is not really suitable for individuals because individual providers are simply not able to bear that risk. It can work for group providers, and it is commonly used for group providers. It may be used for hospitals, but it's not typically used for individuals. The other thing is it reduces choice for patients. That is a part of the bill that requires patients to have choice. And so I think capitation of its nature here may be eliminated from our array simply because the choice is reduced. But we should kind of put that in the marker for further discussion because that is a big issue. Obviously, if you're tied to one particular provider or set of providers, take for example Kaiser. Suppose you're in Kaiser. Well, Kaiser gets a capitated payment, then you can't go elsewhere. It can be very challenging to implement in urban areas because people have to attach themselves to a healthcare provider, and there are many different healthcare providers, and then they're excluded from seeking those providers. Any comments on capitation? Dwight?
Yeah, I just wanted to comment around the low administrative overhead managed. That's somewhat true for the payer. I think at the provider level, it may be a bit more complex still, because even though you're capitated for a population, you still have to track the services you're providing in terms of rate setting to determine that capitated rate. If you're talking about capturing Medicaid and Medicare funding in the future, you've got to be able to justify that rate from the Medicare and Medicaid systems in terms of what they're going to be funding. So there's still, even though it's capitated, there's a lot of fee-for-service aspects on the provider level that make it a little more complex.
Yeah, your point's well taken, Dwight. I was really, I think it's easiest for the payers than it is for the deliverers of the care. So then next slide, procedural case rates. Those are typically used certainly for inpatient. All inpatient hospitals now bill out on case rates. Those are diagnosis-related groups, the DRGs we've all heard about. Those theoretically, and I think probably pretty accurately, take acuity into account. They can, if the case rate is a bundled rate between a hospital and physicians, it can create a partnership between hospitals and physicians. It's certainly a manageable cost structure. It's quite predictable. It's not particularly inflationary. And it is why Medicare has used it for the past 30 or 35 years. It is what they transitioned to when they moved away from the fee-for-service system on the inpatient basis. It does not lend itself as much to individual providers. It can be oriented to outcomes a little bit, but you know, not really a great deal, because most of the outcomes that might be in value-based payments are really not articulated in the procedural case rates as they're organized right now. It does provide comparability between urban and rural areas. As I said, it works best for surgeons and procedurists. They may have a case rate for a cholecystectomy or a delivery or something like that, but for a primary care physician, it really doesn't lend itself at all. It's impractical for primary care, and it isn't really highly related to value or outcomes. Was there a comment? No. Okay, I'm zoom.
I know that Cheryl indicated a comment in the chat box. Is that right?
Yeah, it was actually on capitated.
Oh, so sorry.
Yeah.
I was too late to the
Just
game.
wanted to add.
Do you want to go ahead and
Oh,
yeah, let's hear it.
In the, you know, as we're in this pandemic, you can imagine that people who need behavioral health care may not have been seeking behavioral health care, especially as we were trying to work out the telehealth and telephone glitches and things like that. So then the numbers of you know, fee-for-service encounters decreased. So those who had fee-for-service arrangements with their CCOs saw a very steep decrease in their revenue, as opposed to those who had capitation arrangements. You know, they were able to do way better. And so we've seen that across the board, because we have community mental health programs across the state who have varying payment arrangements with their CCOs, and I've seen this to be true. And with the other behavioral health providers as well, this is particularly been a problem when they have fee-for-service arrangements mostly. So
yeah, great point, Cheryl.
Yeah.
Great point. Okay, so I'll continue along here. Bundle payments. The idea of a bundle payment is typically occurs between maybe hospitals and procedurists, surgeons, that kind of thing. And the idea of a bundle payment is that you and I as individuals or even payers really don't want to buy things we don't want to buy a car by the wheel. We want to buy the whole car. And so if we're doing labor and delivery or we're doing a particular procedure, the payers and the individuals that all wants to be sort of bundled into a sort of a reasonable boundary, and that's the notion of these bundled payments. So it can take acuity into account, and it can be comparable, because clearly if you have bundled payments, you can compare them between teams. And it's clearly a manageable cost structure, because rather than onesie twosies and a day in the hospital and a test here and a test there, you're making a single payment for the entire thing. And if they don't provide the service, then they still get the same payment. And if they provide more services than are reasonable, then they're still getting the same payment. So it's increasingly used by Medicare and by other payers as well. And it does have some comparability between urban areas and rural areas. I mentioned the urban and rural because it's a big part of this legislation, and it's a big area that we need to be thinking about how to ensure that rural areas that have fewer providers and so forth, we put some kind of compensation system in place that works well for rural areas, tribes, things like that. And the cons of bundle payments is that clearly it doesn't work for primary care diagnosticians, things of that nature, or episodic care. It wouldn't work, for example, really for an emergency department or something like that. So it's of a fairly narrow value. It's a good tool, but it's a fairly narrow value, and has to be put in place with some other schemes as well. Salary is the last one on my list, you know, really salary, which may be commonly used, may be used actually in behavioral health organizations that are part of an organization and receive a salary. It could be used in a whole variety of healthcare organizations. Kaiser, for example, very commonly pays its providers on a salary. So if you're compensated on a salary, then you are really not individually incentivized in any particular manner. So it's managerially very easy to operate. The problem is, of course, that individual providers, you can't, it's unreasonable to salary most of them if they're individual people with an individual license, a primary care provider and sisters or something like that. Salary may be so, particularly if it's inappropriate or improper, they were view it as improper, you may have a problem with recruitment. That's a separate area for us to discuss later, but I just wanted to point that out. So I think it can be suitable for institutional employment if you're part of a large organization. Take a group practice, for example. They might be capitated. They might receive that payment per member per month. They move it into the organization, but then the individual providers are not capitated. The individual providers are employed and they receive a salary, and that works out pretty well. The law is pretty specific regarding incentives, and you cannot create incentives to reduce care to individual providers, and that's in, I think, was the group practice dialogue there as part of the statute. You know, salary is there for individual providers, but it is not really a major aspect. It doesn't take things like workload into account. And as I mentioned, it's not suitable for individual providers. And Laurel, I am on schedule.
Am I on mute? Can you hear me? I am so impressed, Dr. Chadwick, that you made it. That I'm impressed with all of us that we made it to this moment here. Today, it's time for discussion. I sent these discussion questions yesterday ahead of time in case you wanted to be thinking about them a little bit. We put these out to try to foster dialogue discussion, but we generally want to hear just your reactions to the information we just provided. Some of those specific questions: to what extent does what Dr. Chadwick just presented map on to your personal experience of the pros and cons of these various reimbursement models? And how does that analysis inform your opinions on how this healthcare plan should reimburse individual providers. Let's start there, and then we can move on to potentially the third question, which is what other information or resources do you need? Yeah, Deborah.
Yeah, thank you, Dr. Chadwick. Chad, thank you. No, so the way you framed it does resonate for me, and I think that the comments that were made on the mental health side definitely need to be lifted up. I can't get to the second question, but rather, again, as usual, have to jump to what additional information. And as you were going through the analysis, what sprung to mind for me, and I jotted it down, was have the failed efforts across the country where folks have tried universal health care used mixed methodologies? And if so, how did they determine which complementary methods would create the best opportunity for success? Like, again, if they've only done one thing, then that's clear. But if they've used bits and pieces of, you know, we'll bundle here and we will do, you know, some salaries here, you know, how did they go about that framework? That would give me more information as to what might be a good course for us.
Deborah, would you mind, you said you wrote that question down. Would you mind putting it in an email or in the chat, just so I can make sure that I've captured all of it?
Absolutely, thank you.
Thank you.
And as a follow-up, Deborah, I want to make sure I'm understanding the question now for purposes of this discussion. Are you asking about the other states that put forward proposals that didn't? Are you essentially asking what reimbursement methods did those other state proposals include for individual providers?
Yeah, so if I can figure out, you know, which states who've tried universal access have failed, right? But they did have an attempt, like what was some of the calculus that went into that? And what did their schedules look like? And again, it's just to try to glean some information on what didn't work to see whether it didn't work and it wouldn't work here because we're identical, or it didn't work there, but it might work here because we're just completely different. So I'm just trying by process of elimination to try to get some lessons learned.
That's helpful. Thank you. Dwight.
Yeah, I think one of the overarching issues for me through all of these different models, and I appreciate, Chad, your work on this, where does the risk sharing come in within each of these models, and how is that managed and handled? I think that's another important issue that needs to be addressed for each of these models, or whatever model we may come up with ourselves. So,
Dwight, it's a big issue, and I guess I scooted through it pretty quickly, but we could come back onto it and really do a little chart on risk, and that would help people sort of understand whether the risk is on the providers or on the payers or on both.
sure. Thanks.
Could I add? Okay. First of all, thank you for doing this pros and cons analysis. I think it was really helpful, Chad. I would agree with Deborah. I'd really be interested in seeing how the other states were attempting this. I saw in the chat that Oliver said it was not very specific, but I'd still like to know. And then I hate to be a pain, but I think there needs to be some level setting between behavioral health and the physical health care system. And that means that, first of all, in terms of risk, the behavioral health system will not be able to start with upside and downside risk. I just think it's unrealistic because we've got so few of the resources. I think that we need to look at that. And then I would say that there's no way we could just choose one of these reimbursement models. I honestly think it's got to be a mix. That's what I've been seeing, and that's what I think. I can't imagine just moving like everything from fee for service to, let's say, capitated payments. I think it depends on the service or program, honestly. So I just like us to maybe differentiate or take a look at how behavioral health is funded now and how we would lift it up. to the rest of the behavioral health system. I'd also like to see more on shared savings. I can't remember if that's coming up and how that works. And so, for example, if we do a good job of supporting the behavioral health system, reimbursing appropriately, providing enough resources, I think that we could have a lot of impact on the medical part of the system in saving costs there. It's hard to track what you're preventing, like it's hard to put a dollar amount on that, but I think that we need to look at that as part of a cost savings too in all of this. And again, that's really difficult. We've been trying to make that case, and it's difficult to get the data that we need.
Cheryl, this is Chad. I'm curious about this notion of value-based in behavioral health. Seems like the outcomes might be quite, I don't know, in some cases maybe very difficult to quantify.
Yeah, you've hit on a big challenge of ours, and it's actually a planned action for both OHA, the Health Systems Division, which houses the behavioral health office, and our association to come up with a few key outcome metrics. So yeah, it's a really big challenge.
Cheryl, your comment. Oh, please.
No, go ahead, Laura. No,
Okay.
wrap that up, please.
I'm so sick of hearing my voice. Please.
No, wrap it up because I have another comment, so that's okay.
Well, what I was just gonna say, Cheryl, is that your comment about it's not going to be one size fits all. We're going to need more than, we're not going to be able to shift to like one method. That is captured in the language of the bill. And thank you for reminding us of our task here, because the bill does say that providers shall be reimbursed as follows, or using an alternative method that is similarly equitable and cost effective. And so our task here is to, I think, evaluate sort of the outline that the bill provides, and also consider if there's anything else that we want to add in or modify in what we're ultimately bringing to the task force to include in its recommendations on the plan. And the language here in the bill is very, does suggest that, that providers shall be reimbursed on a fee-for-service basis, or using global budgets, or as using capitation in the case of group practices. So thank you for highlighting that variance is likely going to be key.
Well, and maybe it needs to say and or, to accommodate any of those combinations. But I get your point. Thanks.
Yeah.
It's probably going to be some kind of a, at the end, whether it's done at our level or at the task force level, some kind of a sort of a matrix, which, goes through a lot of these different categories and sort of identifies, at least from our basis, those areas that are not compatible with the law and with our values, and those which are.
I was gonna ask a question. I noticed in the bundled payments, and then maybe even one of the other categories, that those methods or payment models are specifically used for surgeons and procedurists. And I'm wondering if there's a reason for that, meaning like, are there certain ways that surgeons and procedurists have to be paid that we have to consider, or could we move those particular specialty groups to and through another kind of payment model? I don't know enough to know. And then I think about the ways that the like wide variance in how much providers are paid, right? So for example, one insurance provider may pay me $57 for a patient that I've just spent 2 hours with. And then somebody, maybe a surgeon or procedurist, or maybe another specialist, would spend 2 hours either through fee-for-service with a whole bunch of different codes, or a bundled payment that would provide them, a much higher rate. And I'm wondering, in a universal healthcare system, how do we account for that great variance between how much providers are paid? Because I think where we may find opposition in moving forward with the universal healthcare system is if there are certain providers providers within our current system who reap large financial benefit from the payment models, methodologies, et cetera, then they may be resistant, right, to wanting to be part of a system where we either begin to level out some of the payments or begin to balance it a little differently. So I would be interested in that. Also, I know, for many years, at least as part of the traditional health worker field, but also really in alignment with value-based payments, we've really been trying to move away from fee-for-service because we know that it just doesn't meet the needs of most patient populations, especially underserved patient populations, underserved by our current medical system, or individuals who face the greatest health inequities. And so I would love to have a framework on these pros and cons that really look at the communities whose health impacts or whose health disparities are greatest, to see if the payment types are actually most beneficial for those communities. That would be really great to understand as well.
And Xenia, if I could just add on to that, I think that some of this is associated with really big underlying access issues in terms of availability of different providers in certain regions. That it's almost less associated with the fee-for-service, and the fact that these providers simply are not geographically or for whatever reason not available to huge segments of our population.
Thank you. Dr. Junkier, I know, so I heard 3 different points. I heard you articulate 3 different questions or concepts. The first one you were, I want to make sure that I jot down correctly because I think you were asking for a little more information. You were referencing that in one of these, that procedurists, that one of these one of these models are helpful for procedurists, but not helpful for others. Can you reiterate that question so that I make sure?
Yeah. Yeah, totally. And it was a bit of processing as I was saying it. So in the bundled payment, I see surgeons and procedurists only. I'm wondering if there is a reason that surgeons and procedurists either prefer or this is a payment model that has been used for those groups. If we have to consider that this has to be a payment model, I know it's not like the only ways in which surgeons and procedurists are paid. I'm just wondering if we have to consider it based on the fact that it seems to cover surgeons and procedurists, right? I'm just trying to understand, does this mean that this is tried, true, works really well, meaning the patient gets the best care? We really want to make sure that we consider this as part of part of the payment methodology? Or is it this is just how it's been, it only covers surgeons and procedurists, but it doesn't actually have to, it's just the only way that it's been so far? I don't know if that makes any sense.
It does. Dr. Chadwick, do you want to speak to that?
Yeah, if I could briefly, I think the reason it evolved that way, that it wasn't originally that way, but the idea really had to do with if you think of a procedure, an appendectomy or any sort of defined procedure, it's fairly predictable, if you will. It's going to have X amount of days in the hospital or not. It's going to have certain kinds of inputs. It's going to have a certain recovery episode. And I think the idea was actually to try to create a surrogate for value a little bit by creating these sort of bundled payments to say, why should we pay the doctors and the hospitals and everybody that's involved in this dance differently? Why don't we put you all into the same bin, pay you one time, and you guys figure it out? So it may have had a financial advantage, but I think it also was trying to create a little more cohesive teamwork between the providers of care.
I see. That makes sense. And so it potentially, if we move to if we decide that we don't want to leverage a bundled payment methodology as part of how we are going to pay, then we would have to basically break that bundle up okay, yeah, thank you. I see Deborah nodding, so I'm like, okay, I'm on the right track, at least in understanding what this means. Okay, thank you.
So I'm curious, I want to look at time here to make sure. Okay. Based on this information, you know, what we're going to get to what more information do you need to answer this question in a second, but I am curious just at this juncture, what you all are thinking in terms of the types of recommendations that you might want to be making to the task force with regards to individual provider reimbursement methods.
I'll jump in there a little bit, Laurel. I really think, you know, in order to answer that question, from my standpoint, we would have to go through these individual on a one-by-one basis and sort of chat about it and sort of figure this one out. And I'm cognizant of Cheryl and Dwight's comment on behavioral health, and that will have a unique kind of an answer to it, and others. And I just sort of think, just because it's not one size fits all, I think it's going to take a sort of an answer at the more detailed level, primary care versus, you know, whatever.
I also think, to Deborah's point, it's the cost or the payment variation between different types of payers, like between commercial carriers, Medicare, Medicaid, let's say, but also within even the same payer type, those variances has to be considered. So I'd like to understand that a bit more, how that would work under a single payer system. So I guess where I'm at right now is I don't know what I would recommend to, you know, to the task force on what we should do. I just think it's so variable, and as I said before, I think it's got to be a mixed model. There's just no way we can recommend one particular model. So I know that.
Cheryl, this is Chad. If I could just jump in, I think that there are sort of two variables here. One variable is the mechanical way we approach it. The other variable is the amount of payment we make using that mechanical tool. So you could sort of have capitation. It could be high or it could be low. You could have fee for service. It could be high or it could be low. And I think we have a time to actually discuss that, don't we, Laurel, at a later time?
You mean for the discussion of rates?
Yes.
Yeah. Yes. So we have that in our, I guess it's our fourth meeting. We have set aside for rates. Am I hearing Dr. Chadwick essentially kind of being clear about the percentage of payments that need to fall under each model? Or are you speaking more towards the actual dollar amount?
Are you asking me?
Yeah. Is that what you're talking about?
Well, I was responding to Cheryl's comment, and I guess what I was saying is that I think that there is sort of a mechanical way we approach it. Let's take, for example, for behavioral health, we could say, well, these two approaches work, and these two approaches don't work. And then there's a subsequent conversation, which is, okay, well, if that approach works, then how much would it have to be, or how would we structure the dollar amount such that with that mechanical approach and this rate, it ended up being adequate.
Got it. Thank you. That was helpful.
I think another thing that I'm having trouble conceptualizing is, what do we do about all those services that are subsidized by the state general fund? And I guess I'm talking a lot for behavioral health, obviously that's my context here. So are we deciding all of those services provided are in? I mean, it's hard to say how providers would be reimbursed if I don't know exactly what the service array is that we're including. You know, I think that is going to matter.
I have a request for additional information. Is it possible as we go through our tags, for any tag that is going parallel to our path that are meeting right now while we're meeting, for us to get sort of the decision points at the end of each of their meetings so we can filter that information in? It may give better context rather than waiting for all of that at the end.
So by the end, so at this juncture, the way we've tried to structure it is by creating those meeting summary templates that we're sharing back out at each task force meeting.
Oh, okay.
Does it feel like that meets your needs?
Yes, that would meet the need.
Okay.
And I think that it goes back to what Cheryl was saying in terms of, if I don't know what services the service tag is doing, then it's difficult here. But if, as we're trying to make those decisions, we know what they've decided, then that will help to inform.
Deborah, this is Sarah. I think as the tags get into more meat too, I think having the written summary may even be in some cases more useful than the report out at the task force meeting, because there just may be more information there.
Yes.
And so you wouldn't need to wait until the next task force meeting necessarily, depending on how the tags are scheduled, to have a, what were the main points, what were the decisions, what's the follow-up, that kind of thing.
So would we have access based on the website to all the tags information, or just our own tags information?
The website has the meeting materials for each tag meeting that has meeting materials created. Yeah.
So for example, like the EBA tag met yesterday, they meet again in 2 weeks. That we will have a summary posted for the EBA tag from yesterday's meeting, and that will be well before our next task force meeting. So, yeah.
Could we ask for some kind of a summary from staff?
So these meeting summaries are by summary, Dr. Chadwick, do you mean a summary of the meetings?
I do, but not as summarized as goes to the task force. A little, something in between, that if decisions are made or directions are taken, something that helps inform our tags work.
Yes. Have you folks had a chance to look at the meeting summaries that went out for the task force? No. Dr. Chadwick, have you?
No.
No. Okay. If you guys could, so we've taken a stab, I think, at creating the type of resource that I think I hear you asking for. I can send it out again to this tag so you folks can take a look at it to see if it meets your needs of kind of capturing the decision points in the discussion from each tag meeting. Does that work?
That'd be great from my standpoint.
Okay, great. Yeah, we can send that back out, and yeah, let us know if it meets your needs here. So Dr. Chadwick, I heard you suggest that we might want to go method by method and offer sort of commentary on each method that speaks to provider variance, that we would want to bring back to the task force. Is that correct? Am I reflecting that back accurately?
Well, it's a little bit of a chicken or the egg. I mean, I don't know whether staff or whatever draft a proposal that we react to or we generated in the tag out of whole cloth, but I think that work somehow needs to occur.
Okay. I'm trying.
I don't know whether it occurs here or at the task force level too, Laurel. I'm sensitive to the role of the task force, and I'm a little unsure about what our job is vis-a-vis the task force.
Got it. That's helpful. So as I see it, our job here, and the charters were an attempt to kind of summarize that. And actually, that's a good thing to have in front of us here. Oh, it's so grainy. So our task is to be proposing the methods that that will be used for reimbursing providers. And so we have the language of the bill that we've been speaking to, and our task at hand is to be bringing forward a proposal to the full task force for what the task force should include in its recommendations.
At the detail level?
Well, that's a great question. So I think that I do think that there's a level of detail that we need to hone in on. I think that if we're able, ultimately there will be memos that will be potentially drafted that the charter speaks to. I think it would be helpful. I think what might be helpful is to capture some of this conversation. I think that I can take a stab at trying to capture some of this conversation, and you folks can be reflecting back on it. I'm worried though that we haven't been able to have a robust enough discussion for me to really create something that you folks can be reacting to. How are you all feeling about the chicken and egg question? Yeah, Deborah.
Yeah, so, yeah, I get it. And I know we flagged time early on, but I mean, we're being tasked as a collective to do a really innovative and never before accomplished feat, right? So it's going to take a lot of time, and there are, again, clearly far more questions than answers, or we would have already done this. So yeah, again, the way my brain functions is if I need a decision point resolved before I can go on and address the next piece, I can't just skip over it and get to the next piece yet. So yeah, the information would help. I mean, we have questions about the methods, so we can't get to the payment of the methods until we have some of that sort of shared.
I really liked the idea of talking through the different reimbursement models, and I wondered if we could potentially do that through a framework of looking at either provider types that have historically not been as successful in those methods or models. Cheryl, I know you've brought up behavioral health providers a lot, been successful, meaning those models are not working for certain provider types. I think about, naturopathic medicine providers. I think about other folks who just have not historically had a model that has really worked for them. And I wonder if by thinking about folks who have the gaps within those models, we could get to a place where we uplift some questions that could lead us to what that mixed methodology that Deborah mentioned is, because I do think it's going to have to be that way. I just feel like I still need some information, but I also don't know what that information is. I actually think I need to spend I need to rewatch this after I get off here, right? I need to go back through, make sure that I understand each of the model types. There's just some work that I recognize I need to do on my
own. This is Chad. I think also we're predicated a little bit on the benefits and what are covered benefits, because if something is not going to be let's take, for example, I don't know, acupuncture or something. Well, if acupuncture is a covered benefit, then we have to weigh in and figure that thing out. If it's not a covered benefit, we don't need to put time into it.
I can say that level of detail. So, the tag is not tasked with proposing a reimbursement method that should be used for each bucket of services. I think that is too that level of minutia is going to be not going to be something that we can tackle. I do think, though, being able to capture the general considerations that lead to the need for for multiple approaches is a level that this tag can be tackling. So to your
more
point,
generalized statements?
I think so, yeah.
Well, even if we did more generalized statements, we would still have to break it down a little bit, I guess. I mean.
Yeah, yeah.
Unless our generalized statement is one size does not fit all. Well, then
We
we're
need
done.
more than that. Yeah.
And so I think, so again, I think at least for me, the reason the deliberation is why I'm being so critical is because for me, this isn't just an academic exercise. Like, we are really, truly trying to build something. And so that's why, we can't just, at least I can in a theory say, yep, that sounds like a good piece, let's throw this one on, because I don't know, and I want this to be something that we move towards implementation, right? And so, yeah, I'm going to be a lot more cautious and try to be as certain as I can that what we're producing may not be perfect, but it's the best opportunity that we're going to put out there. So, I'm sorry if I need tons of information.
It's complicated. The other thing I think we need at some point in time is we need some, it's all well and good to hear my opinion, but I think we need some outside expertise, either toward the end or somewhere along the process, to make sure and validate what we're thinking.
I think there's also some foundational principles we need to take into consideration. I think about consumer choice, and I think as we are designing a universal healthcare model, if we look at strictly the CCO model, and we have regional payers and maybe it's a capitation approach, I'm not sure, but there's a whole lot of folks that are going to be brought in, and a lot of consumers brought into a new model of reimbursement that's not going to work well with, because they're aligned with a specific provider, and if they're outside that provider pool, that's going to be an issue. And so I think we just need to make sure that consumer choice is paramount in whatever we develop as well.
So I think I'm hearing a couple things. I think I'm hearing that we're grappling with the chicken or egg question of who is taking a first pass, and who is kind of giving the feedback on that. I'm also hearing that we want to make sure that the voices in this room are not the only voices that are weighing in on this, that we want to make sure that stakeholders are coming into the conversation. And I'm hearing the need to capture nuance and a question of how much nuance and detail we want to be capturing. Those are the main three questions that I'm hearing. Is that accurate?
I would say mostly yes. I would also like to just put a caveat that definitely want to hear from stakeholders who want to contribute to the process and not simply to obstruct. So I just, would like to make sure that folks that we're bringing in have ideas around the things they like and the things they don't like, and how to improve it, so that we are moving towards the end goal.
I agree completely, Deborah. It could end up being a big gripe session if we're not careful.
Dr. Chadwick, I saw you with your head between your hands. Do you have?
I didn't know I was being seen.
How does it feel like now is a good time to pivot into a discussion of stakeholder engagement? I feel like those 3 questions around chicken and egg, level of detail, and the nuance that, and capturing the nuance and variance, are 3 questions that I don't know if we're going to be able to come to a clear decision now. I think they are questions that, frankly, all of the tags are grappling with. I do think that we have had a chance to talk through some of the substantive questions that we want to be grappling with as it relates to individual provider types. So I'm wondering if we do want to pivot then, because I'm hearing that the stakeholder question is a key one. I'm wondering if we want to pivot to that conversation of stakeholder engagement.
Yeah, I think so. I just, one of the things I guess I'd like to do before we finish up today's call is just make sure we're on the same track for our next meeting. So we sort of know what we're doing there. This whole process feels like sort of a work in progress that we're all working on together, and there are going to be new questions as we go along. And I think the best thing we can hope for is to answer some of these and refine our work as we move forward. Hopefully at some point in time we get some more time. So, you know, even though there are more questions than answers, it feels like to me that we're making progress, I guess. So I'm fine with pivoting, but I would like to ask the question just so we know with what you and I had talked about with the next meeting that we're on the same track.
Absolutely. So that there's a slide dedicated to that. Yeah, I think, okay. So I think it would be helpful then to pivot to this question of stakeholder engagement. This was a slide that was presented at the task force meeting. And really, you know, after the first TAG meetings, we tried to capture general themes that we heard across those TAG meetings. And one ongoing question is this question of stakeholder engagement. And staff really tried to kind of put it back to you all and say, it's really an outstanding question that the task force needs to, task force and tags and CAC need to grapple with. There's a question of you know, we need to be balancing timeline, capacity, but we want authentic engagement. And so I know that these tags, one of these tags have been flagged as areas where experts can be brought in to inform the conversation. And so we have been clear that these tags can be a space where folks can be brought in. And I think to Deborah and Dr. Chadwick's point, we just want to be very intentional and specific about bringing folks in. I think we need to make sure that we're bringing forward specific questions and that we have kind of a clear reason for bringing folks in. That's my 2 cents. And I'm curious if that resonates with what you folks are thinking about when we're thinking about potentially bringing other folks into this conversation. I see a thumbs up from Deborah.
Yeah,
I'm saying,
go ahead.
Me?
I guess from my standpoint, I'm thinking that it's a timing question as well. When is the appropriate time to bring somebody else in?
Yeah, it makes sense to me to bring folks in. I also think, you know, I do think with by asking individuals questions and with really tight facilitation, we can create a space where we can have folks come in and provide us with really objective information or subjective from their experience information that we can then take in, and then hopefully that will help us to do something with. Meaning, I want to hear all sides. I do want to hear from folks who would say, absolutely not. If you engage in a fee-for-service model with universal health care, you know, everything is we're just not going to make it. Like, I want to hear that, because for me, I think our role is to take in all that information, to use all of the experience that we have, and then discuss that as a team. So I do think if we bring folks in, being really clear about the questions we have for them, and ensuring that we have a number of different perspectives so that we can take that information in as a group and then make a determination from that.
Could I offer something that I'd like to hear from the CAC, and maybe the other tag on eligibility and benefits might be asking the same question, but to our point in trying to figure out what is in so that we can work on provider reimbursement, I'd really like to hear from the CAC what they view as essential health benefits. I mean, similar to what we were doing on the commercial insurance side and on the Medicaid side, you know, coming up with these essential health benefits right at the beginning of the ACA. And I think that's what we need to figure out is, and I'd love to hear from the consumers on what they view as essential health benefits that would be reimbursed to providers. So as a starting point, I also wanted to mention back to this question of the variability of the payment and, you know, what's covered and everything. One thing, like I said, I didn't read all of the materials you sent very well, but I did do kind of a skimming of the CBO report. And one big question was whether you negotiate rates with the individual payers, carriers, or you just set a rate for everybody. And I think that's a key question in my mind, but maybe it's not for this tag to decide, I suppose. But I do think that would answer, you know, our question, you know, in terms of like, how do we deal with all of these different payers who pay different rates or negotiate them? And actually that comes to a very big fundamental philosophical question in my mind on whether we're all willing to move away from a capitalistic model of healthcare, because that would definitely move us away from that model.
This whole dialogue moves us away.
Yeah.
To your question, Cheryl, about, or I don't know if it was a question, but a statement around deciding who negotiates rates. I think that's absolutely in the scope of this tag. I think we have a whole meeting set aside to talk about rate setting. So I'm really glad that that's a question that you have, that we want to be thinking about. And thank you for kind of flagging that that's really addressed in the CBO article, so we can make sure to circle back to that CBO article when we do have that conversation around the question of rate setting. I know when we initially created the outline for these meetings, we kind of felt like we need to talk about the models before we talk about the rates, because we need to know what we're setting rates for. So I guess I just want to offer that I definitely think you're thinking about the right things, and that this tag is the place to be thinking about that.
Okay, great. I wasn't quite sure.
Yeah.
Mm-hmm.
But, you know, as a practical matter, we're talking, unless I'm off base, we're talking about a single payer. And the notion of a single payer is the state is the payer. And that, by definition, really takes all of the other payers out of the dance.
It seemed, though, if I'm not mistaken, that the Germany and maybe Switzerland, well, Germany and I can't remember, one of the models is that they didn't have like one rate for everybody, that there were some differences. Again, I didn't read it very carefully, so I'm forgetting exactly, but I thought there were some variations there.
Cheryl, I think the distinction is between the notion of universal coverage, in which case you can do sort of a patchwork approach to coverage, or universal single payer, in which case it is a single. There are very few examples of a single payer. Probably the NHS in the UK is the biggest example of a single payer. And maybe Canada as well.
So this conversation is all very, very helpful and informative. I want to make sure that we are getting kind of some clear takeaways on going back. We've kind of been jumping around a little bit, and I've wanted to allow that to happen to facilitate this flow of ideas. But I do want to make sure that we're landing somewhere on this question of stakeholder engagement. I'm going to pause and ask Sarah Nipper if we do have anyone set up to offer oral testimony today.
No, we do not.
Okay, so we have, that's helpful. That gives us another 10 minutes. I want to make sure folks know on the phone that even if you don't want to provide oral testimony today, you can always provide written testimony, and there's a link to do so on the website. So landing this question of stakeholder engagement, I heard that there are questions about timing and about being specific about what we want to ask them. I'm going to ask a very pointed question. Do we want to invite stakeholders to the conversation about that around institutional provider reimbursement?
I personally think we do, but I don't think we want to. I think these forces, these groups need to have something to react to, as opposed to, if they're involved with us too early, I fear that they could just throw mud around the room and keep us from moving forward. So I think it's very important that they have an opportunity to express themselves, but I think the timing is very important.
Am I hearing then that perhaps next meeting might be too soon?
I would think so. I don't think we have clearly identified any of the decision points. We're still under consideration of a lot of pieces. So to have others come in to react as we're still deliberating, I don't think would be necessarily helpful in this space. I think one of the things we might be able to move is Cheryl's question of what does the Community Advisory Council or committee consider to be essential benefits, because that will track back to who the essential providers are and will give us at least some framework for, how many folks and how many kinds of services we would be considering under a payment model.
Yeah, I also agree, thinking process-wise, I do think engaging our CAC before we engage our stakeholders, and then also circling back with the CAC would make a lot of sense, just as far as, the decision-making bodies we have set up already. And I think we have a little, I think we can do that more easily in the next meeting or, the subsequent meeting.
So then in terms of engaging the CIC, I did write down Cheryl's question, what do you view as essential health benefits that you want providers to be reimbursed for? Are there other questions coming out of this conversation that we want to be posing to the Consumer Advisory Committee?
I'm curious about their feeling about cost sharing and co-pays and those kind of things. It's a very emotional topic. It has a lot of bearing on a lot of the way that people deliver care, and it seems to me the CAC needs to opine on that.
Yeah, I also think, as long as we're sort of querying the service, essential services, what services they believe to be of lesser value. You know, and again, value is relative, right? And so I don't know whether we frame that in terms of your outcome, the time spent in order to acquire it, you know, but I think that if we could also figure out, you know, on their lowest end of what they might be willing to cut out, that would be helpful as well.
And I think those are pretty big questions that could take several meetings on their part. I know the essential health benefits work groups met for many, many months when the ACA began. So,
and I'd like to give a shout out to Xenia, who has endured now 3 meetings this week. I think you're the only one that is on both tags.
I think Deborah is too, aren't you?
Deborah is too.
I'm like, I feel like a number of people in this group are, but maybe I'm just used to seeing folks in different spaces.
Deborah, I'm so sorry. Equally shout out to you.
Thank you.
Is there anything you want to offer from that conversation?
I mean, I think we ended up in the same place where we took in the information that was offered. We thought it was great information. We had lots of questions. We felt like we couldn't really make a decision. We wanted to engage the CAT, and we need more meetings, but we have little time. I mean, I think we're kind of in the same place.
Laurel, I have a question for you. Does the CAC, you know, we have sort of the task force, I think wisely decided to sort of place questions over to the CAC. I'm wondering conversely if the CAC is going to raise questions to us.
I think that's a great question. And I do think it's one of the questions that we kind of posed to the full task force on Wednesday, of this question of stakeholder engagement, that we do need more direction on. What is the process for us engaging the CAC and the CAC engaging us? And I think we tried to kind of present it to you all that that is an outstanding question for task force and CAC leadership. I think, am I hearing that that might be, I guess, pivoting now to the report back? Is that something that we want to be posing back to the task force and CAC leadership of saying, we'd like to hear questions from the CAC? I see a thumbs up from Deborah.
Yeah, I think open dialogue is good. Again, as long as we are all grounded in what the end goals and the movement of the process is. I also think that at least the way I would frame questions that they don't already have, is that once we've made some decision points or some I don't know, some decision points, that they react to that before we sort of ground it in the recommendation. I don't want to get too far in our own heads with what we think is a great idea without engaging them on what we think is the final product, because that's kind of how we got the system that we have, right?
Okay, so that's helpful. So we'll definitely flag that in the report back. I think before we go there, I want to make sure that we just dedicate a couple minutes to this question that was lingering at the task force meeting. I want to apologize because there was a timing issue of when I got Cheryl's suggestion, and I was hoping that Cheryl and Dwight would be able to uplift the suggestion and it could get packed in at the task force meeting, and that didn't happen. This morning, I had in a slide Cheryl's suggestion, but then I remember at the task force meeting, Dwight offered that the language of the bill already addresses this issue by saying individual providers licensed, certified, or registered. I offered this modification here. If I could just see, does this seem to kind of capture that conversation and the question around how we are modifying individual providers? Does this language now kind of address that conversation that we were having at the task force level?
I don't know that, again, I'm relatively new to the state, and I'm hoping others will inform me. I don't know that licensed, certified, or registered captures both the community health workers, the traditional health workers, and some other allied connectors. right? And that connector, you know, might be a systems connector. I'm not quite sure, you know, but those complementary services, especially for communities that really don't understand navigating the system or may have other community kinds of sensitivities and values, are invaluable. When we talk about value-based, for those communities who rely on folks who look like them, who speak their language, who understand their lived experience, those are essential providers. So, and I don't know that all of those folks are licensed, certified, or registered.
And I wonder if there might be other people that provide services that even are outside of this category. And I'm curious whether it opens a Pandora's box to put the word employed in there. I don't really understand this, I guess.
So I do want to offer that this is intended to be kind of a scope, not a policy recommendation. You know, these charters are intending to kind of outline the scope of what we will be tackling. I'm wondering if we simply want to say individual providers shall be in the state shall be reimbursed, and then that, or individual providers in the state shall be paid. And then that way this tag can kind of grapple with this question of what an individual provider is.
I think that makes sense. I can say that for the purposes of actually getting reimbursement from a payer, you would have to somehow be licensed, certified, or registered. Otherwise, I think services then have to be paid or subsidized by the state or county or, you know, some sort of grant. So I think those are very important in terms of getting reimbursed. And if we're looking at, you know, coming up with a single payer plan, I mean, maybe we will not have those types of parameters, but right now that's how it works.
Yeah, that's a good point, Cheryl. You know, as far as traditional health workers, I'm thinking about like community health workers and doulas and, you know, peer wellness specialists, and, you know, they continue to add categories in there. And there are some, you know, anyways, all of that to say, you know, there are certification processes for folks. I do think the like piece of my, like, you know, advocacy world hat is like, well, then we have to make sure that, you know, the background checks and the things that are related to these particular provider types are not prohibitive, so that we don't end up with, you know, certified providers who can't actually be certified because, you know, you all know.
And that's the current status. That is true. That's a huge challenge right now.
Yeah, absolutely. And the fact that even internally within the Office of Equity and Inclusion, they don't have enough FTE to actually process the applications or the certifications or the continuing education forms. And so you've got on a fax machine, you know, 75 folks, you know, worth of paperwork that doesn't actually get processed, so they can't actually be certified, right? So there's all sorts of other pieces in there that would need to be funded to ensure that folks could be certified. And I just wonder if, like, individual providers with an asterisk, because I think that a lot of the traditional health workers, at least that I've worked with or, you know, known in the past, I don't know that they would see themselves as an individual provider. And so they may, and I don't know that they would necessarily see this charter and engage with it. So I'm not sure if it's as important to know that when we say provider, we mean a very broad, like, scope of providers, but just living somewhere, you know, we have an asterisk and say, we mean a broad scope of providers, not yet defined, et cetera, so that we don't begin to, like, limit ourselves, you know, unintentionally.
So to that end, Dr. Drunkier, do you feel like individual providers, I mean, similarly, the way we have institutional providers shall be paid down here, do we feel like just saying individual providers shall be paid up here? Because again, this is just proposing methods.
Right. I mean, I think you pointing out that it says individual providers shall be paid makes me think, yes, we should align the individual and the institutional providers. And it seems to be the most broad way to define providers at this point. And so I don't yet think we're in a place where we are narrowing down or need to be narrowing down. So that would make sense to me, unless that inadvertently leaves out folks for whom licensed, certified, and registered somehow notes their provider status, which I don't think is the case, but I'm not sure.
I guess from my standpoint, I think maybe leaving it undefined right now is good. And it leaves us open to the possibilities later, I think.
Okay. I'm hearing
What is Dwight? Dwight, what do you think about that?
did he drop off?
Yeah, I think we must have lost him. I don't see him.
Let's see.
I mean, the problem with adding certified or registered is that it seems to imply that nothing else will be permitted. And maybe that's more restrictive than we want to take on at this point.
Okay. So in the charter that we'll kick back to the full task force, we'll just have A and B kind of be aligned and get rid of those modifiers for individual providers. Oh, here's Dwight. So I'll have it read, individual providers in this state shall be paid, and institutional providers shall be paid.
Sounds good. Thank you, Laura.
And that correlates with the legislation, right?
Yeah, I'm actually realizing maybe it should just say individual providers shall be paid and institutional providers shall be paid. Get rid of the state. Because the legislation says that individual providers are defined either as those licensed, registered, certified in the state, or those licensed, certified, registered in the state or another country.
Basically, it's going to be answered by the fact of whether we devise a compensation or reimbursement for them. If we don't provide a reimbursement for them, it becomes a moot.
Okay. So I think I have clarity on that question. We have 2 more minutes left. And I know that we want to talk about, I think that in our report back, I think that we have a lot that we can summarize here. Instead of focusing on this question, I know Dr. Chadwick wanted to make sure that we check in on our next agenda. We had mapped out that the institutional provider conversation would be a similar format to the individual provider conversation. Does that still feel right to folks? Dr. Chadwick, any additional thoughts on?
Well, we also, the statute provides for discussion regarding capital reimbursement as well, and we're going to throw that into the conversation as well. So that would be an opportunity to discuss sort of the same kind of model, really. And so to some extent, we're going to be going over the same terms again, which might be helpful for some, and in the context of institutions, and then talk a little bit about capital financing as well, which applies predominantly to institutions.
Anything else that folks want to add to next time? Okay. We are exactly at time. I want to thank you guys so much. I realize that there's a lot of question marks still, but I do feel like we've made some headway in a general direction. So I want to offer that reflection back. Dr. Chadwick, any final words that you wanted to offer?
Well, I just want to express my appreciation to you and to Sarah for providing all the staff support you do for us. I know there's a lot of work that goes on between these meetings that you guys do. And so thank you for that.
Thank you so much. It's a pleasure to be doing this work with you all. Okay, well, that's time. Thanks, everyone.
Thank you. Thanks for your
Thank
presentation.
you. Have a great
Happy
weekend.
Thanksgiving.
Happy Thanksgiving.
Thanks to you too.
Thanks, everyone.
Bye.